Jatinder say? Indian design to prevent Argentinian sign in intumescent cataract.
Yeah.
Over to you, sir.
Good morning. My topic is prevention of Argentinian flat sign by an Indian design in cases of intumescent white cataract. Slide is not moving. Slide is not moving.
Slide is not moving.
You see, there is no standard definition for intumescent cataract given in the literature, but Centurion made it an objective assessment by any cataract thicker than 5.5 millimeter with flocculent white cortex and anterior chamber depth less than 2.2 millimeter. The general pathology in intumescent cataract is high intralenticular pressure, loss of structural integrity, and there is thinning of the lens capsule which tends to extend equatorially. So we did a study where we did AIOS-OCT guided management of intumescent white cataract, because we found that in some of the cases of intumescent cataract, you get Argentinian flat sign, but in some of the cases, you don't land up with this dreaded complication. So our primary objective was to evaluate the incidence of incomplete rhexis in AIOS-OCT guided management. And so this was done in Department of Ophthalmology at Deen Dayal Upadhyay Hospital in New Delhi. It was carried on 50 patients for 1 year period from January 2023 onwards. And these were the inclusion and exclusion criteria. The method of measurement of outcome of interest was based on AIOS-OCT. We found whether there was presence or absence of fluid pocket, subcapsular fluid pocket, or intralenticular fluid pocket, and what is the location of these, whether it was peripheral, central, or both central and peripheral, which we labeled as diffuse, and what is depth and size of this fluid pocket, because we found this helped us in better management of our intumescent cataract cases. So group 1 was 25 patients, which was having absence of fluid pockets. Routine CCC was performed. And group 2 patients were having peripheral subcapsular fluid pockets, where we did 2-stage central capsular access, because we found when there is peripheral subcapsular fluid pocket, you can still without any risk touch the center, but only thing is you have to do 2-stage central capsular access. But patients having predominantly central fluid pocket, this is tense bulging fluid which is making the capsule very tense in the central part. So we did not touch the center of the capsular bag here, and we went through the periphery, and this we labeled as a peripheral capsular access. So these are some of the OCT picture. The first one is predominantly central fluid pocket, second is predominantly peripheral fluid pocket, third is both central and peripheral, and fourth is intralenticular fluid pocket, and there is no subcapsular fluid pocket. So based on this, we made an algorithm with subcapsular fluid, and if it is central, go peripheral, and if it is peripheral, go central, and without subcapsular fluid pocket, then you can do routine central capsular access without any fear or danger of having Argentinian flat sign. So this is 2-stage capsular access, where you initially made 3 millimeter central capsular access, aspirate the fluid pocket and decompress the capsular bag, and then give a nick in the equator of this circumference of this small capsular access, and extend it to the desired size of 5 to 5.5 millimeter capsular access. And where we did peripheral capsular access in the central fluid pocket, or both where central and peripheral is there. So what we did here was we bent needle, 26 number needle at the junction of outer 1/3 and central 2/3, go through the side port, and again make a nick in the peripheral of the capsular bag. That is again junction of the peripheral 1/3 and central 2/3, while going with the bevel down. While going inside, aspirate the fluid pocket, and then after filling with visco, give a radial cut with micro scissor. After this, 2 peripheral cuts are made, and then 2 peripheral flaps are raised. I'll just have a small video on this.
Time is up.
The video is not running here. It was running there. No. Mind you, with bevel downwards, you go inside from the periphery, aspirate the fluid pocket so that you decompress it. Now you make a linear cut with a micro Caesar and then 2 perpendicular cuts. So you have 2 peripheral flaps which are raised. Rotate one circumferentially and then you rotate the second circumferentially, and these two are joined. And what you get is a round circular opening without any danger, because the reason was because of the central fluid pocket, you have not gone through the center, you have gone into from the periphery. So what are the observation and results? We had central subcapsular fluid pocket in majority of these patients, that is about 16 patients, and peripheral fluid pocket was there in 6 of these cases. And the complete rhexis was obtained in 25 of these, that is about 100%, and where fluid pocket was present, about 96%, that is 24 of 25 patients, we were able to make a complete rhexis. So there was hardly any complication, and you were achieve almost 96% success. In one patient where we were not able to, where we had equatorial extension, was because we did not go from the junction of the peripheral 1/3 and central 2/3. We were too peripheral, and maybe because of the zonules there was traction and it went equatorially. So in our patients without fluid pocket, capsular rhexis was complete in all the patients. And in patients with fluid pocket, where we did peripheral capsular rhexis, we were able to achieve success in 96% of these patients. So we use preoperative AIOS2025 as a guide to decision making our capsular rhexis technique based on objective assessment of presence or absence of fluid pockets. AIOS2025 can identify true intumescent white cataracts with imminent risk of capsular rhexis extension. It could help formulate a management plan based on the presence or absence of fluid pockets on AIOS2025. In our study, we observed that 25 patients having fluid pocket, capsular rhexis extension was noted only in 1 case, and where there were no fluid pocket, no peripheral extension was noted. So future recommendation is that employing just one technique for all types of intumescent cataract will not yield you safe 100% results. Presence or absence of fluid pocket and the size of fluid pocket can help us to decide about the technique of rhexis that you should adopt in various types of intumescent cataract. And AIOS2025 can really be an objective tool to assess which cases, which technique should be applied. So take home message is, knowing what you were going to encounter on the table beforehand pre-operatively helps you to be better prepared to handle such cases, rather than discovering it on the table during surgery and then deciding what to do about it. Because forewarned is forearmed, and employing one technique for all types of intumescent cataract will not yield the desirable outcomes, because one key may not open all the locks. Thank you everyone for your kind and patient hearing.
Dr. Bhalla, everybody doesn't have an anterior segment OCT. Yes. So this is, you are assessing it on the basis of an anterior segment OCT, with the fluid pockets on the basis of that. So I think your few people will be lucky to have anterior segment OCT before tackling an intumescent cataract. So I think many might have to resort to other methods.
So my humble take on that is, these days OCT is available with most of the practitioners, so you can make assessment. But even if you don't have anterior segment OCT, what you can do is adopt peripheral rhexis in all your intumescent cataract, because majority of your intumescent cataract will have central subcapsular fluid pocket. So irrespective of whether you have AIOS2025 or not, adopt this technique and you will be happy to know that you will not have peripheral extension and Argentinian flax. And this is what I have been doing.
Take home message is that the bevel should be down.
Bevel should be down.
And it should be in between the 2/3 and 1/3 of this thing, 2/3. 1/3 in inner, and it should be eccentric.
At the junction of the peripheral 1/3
and a central 2/3, and it should be this thing. You should make a puncture there.
And then aspirate, and then make with a micro rhexis forceps, make a radial incision right up to the center. Now you will have 2 flaps. Go through the side port, rotate one flap and to almost 180 degree, and from the second side port pick up the second flap and again rotate it circumferentially. Join the two, you will have a complete round circular opening.
Okay, thank you so much.